All right. Welcome to Keeping in Touch. I am Cindy Rubin. I am a pediatrician and breastfeeding medicine specialist with a practice called In Touch Pediatrics and Lactation outside of Chicago in the western suburbs. And welcome, everyone. If you do have any questions today, go ahead and put them in the comments and we will review those and get back to you. So today I am joined by Dr. Edward Wing, and Dr. Wing is an obstetrician and gynecologist, and he practices in Suffolk, Virginia. He is the founder of Lifetime Women's Health and has a great interest in educating his patients and others in the steps that lead to good health. He has specific expertise in the diagnosis and treatment of heavy menstrual cycles, and I will put his contact information in the notes so that you can reach that, but he's at lifetimewomenshealth.net. Welcome, Dr. Wing.
Thank you. Great to be here.
So happy to have you. So today we're going to talk about something that I think, I get asked a lot as somebody who sees women postpartum, which is what to expect in terms of normal, typical bleeding, vaginal bleeding after having a baby, and what it may look like when it's not normal and what to do. But before we go into that, I would just like to hear a little bit about you and your practice and how you decided to do what you're doing.
Well, I am originally from New York City and did my medical training there, went outside of New York for undergrad, but kind of had a very wide range of places that I worked in, from university type hospitals working with residents to smaller private practice to a multi-specialty group, and finally starting my own practice. We just celebrated our 10th year.
Wow, congratulations.
Thank you. And we're very excited about that. And it's been a great experience and a great time doing this. It's just a different way of seeing patients when it's your practice and you can kind of do things that you think are the best way, as opposed to, being in all those other types of situations where you're kind of listening to what other people, leaders and supervisors say about how things should be. So.
Right. I think it's harder for OBs to do that because you kind of have to work at a hospital as well. Are you at one hospital or multiple hospitals?
Right now, I'm just at one hospital, which is great.
Good.
I couldn't imagine having two people in labor at two different hospitals and having to make serious choices there.
Yes, that would be tough. Well, cool. Well, congratulations on 10 years. That's fantastic. I've only got one under my belt, so I can only imagine.
The other 9 are coming.
Yes. Well, let's get right to it. So tell me a little bit about how you probably counsel your own patients on what to expect after they deliver and what I'm sure there's a range of normal, but what moms can kind of expect after they have a baby in terms of vaginal bleeding. I think people don't really think about this very much.
Right. I think there's a wide range of normal. And, one of the things that I always speak to my patients about is not listening to others too much.
Yes.
Because what happens is, they get some information from a family member or a close friend who tells them their experience of childbirth, and they think that, well, that's what's going to happen to me. And, I tell them over and over, their experience, right. Your experience is going to be your experience. And I usually speak in generalities of the things that could happen, but never specific, because we kind of have to take it as it comes and go along. But, right. The practice of medicine has kind of gotten to the point now that there are just a series of things that we do to keep the patient safe during the childbirth. And some of them are things that, maybe some of your patients experienced when they delivered their children, but didn't know exactly why we were doing it or what it meant. It was just kind of like, oh, why is the doctor doing that?
Right.
That's weird. kind of thing.
Right.
But, what happens is after the baby comes out, usually there's some bleeding that's associated with the delivery of the child. And then the bleeding kind of gets going, I'll say, when the placenta starts to detach from the uterine wall.
Okay.
And actually, just as a side note, I find the placenta is just an amazing thing if you think about it. It stays stuck to the uterine wall for 9 months and then comes off within a matter of minutes.
Wow.
And
Yeah.
so it's really, really cool that, it's designed that way. So it's
Yeah.
wonderful. But when that happens, if you've been pregnant, you can imagine that when the baby and everything was inside of you, your uterus is almost up to your ribs. And after the baby comes out and after the placenta comes out, your uterus goes down to a size that's just below your belly button. So it
Wow.
loses a lot of its volume
Yeah.
in a very short period of time. And what happens is if you think of something that's been stretched out for 9 months and then suddenly there's nothing inside of it anymore, it's going to be very floppy. And the main way that the uterus stops bleeding is by contraction of the blood vessels. And so what happens is the uterus is a muscle and the uterus contracts down and gets to that small size under your belly button. And in that contracting down, it squeezes off all the blood vessels that are bleeding from the delivery and from the placenta coming out. And that's how bleeding slows down, at least, if not stops.
Okay.
And so some things that we use to help that along, we give some oxytocin, which is a medicine that causes the uterus to contract. Maybe you've heard that term when we talk about inducing labor to make contractions come. And you, Dr. Rubin, probably know it very well from the lactation. It's a very
Yeah.
important hormone.
Oxytocin, pretty important.
Very important. It causes the milk to come down in the breasts. And so, one of the things that we do is we give an infusion of that in most cases. The other thing that we do, and I'm sure most of your patients who given birth get their tummies mashed. There's a massage of the uterus that happens. It's not the most comfortable thing in the
No.
world, but very, very necessary because it
Okay.
actually helps the uterus to contract down. Sometimes we might even insert a finger into the vagina to make sure that there's no blood clots that are keeping the uterus from contracting down fully. I wouldn't say that we do that on every patient, but in some patients, if the bleeding continues, sometimes we have to do that.
So this is something that you maybe would be doing the next day if there's more bleeding than
Um,
you expect, or a few hours
no,
later?
usually at the time of delivery, but it can
Okay.
be done, the next day if,
Okay.
the patient is still having a lot of bleeding. And then that oxytocin solution will stay on for usually a couple of hours. And usually I've gone after the delivery and everything's finished, I leave, but the nurses will kind of follow up and do that uterine massage quite frequently.
Okay.
At our hospital, they do it about every 15 minutes during the first hour or two after delivering. And it's really to assure that uterus stays contracted because, heavy bleeding happens when the uterus kind of loosens up. And that's a condition that's called atony, Atony. Now, I'm not going to give too many doctor terms, 'cause many of us don't know Latin and all of these things.
Right.
But actually, atony makes up 80% of all the cases of heavy bleeding after delivery. It's just where the uterus doesn't stay contracted, it loosens up, all those blood vessels, are no longer contracted. And
So it translates into no tone, right?
yeah, that's
Yeah.
correct. So, the experience that a patient might have is just very individual. I have patients who the next morning they tell me, oh, I'm still having heavy bleeding. And I have other patients that tell me, no, I'm just having spotting. And so it's just very variable. And I can't say that I can tell you why it's variable. It's one of the things that is. And we just have to keep an eye on it.
Yeah. And vaginal bleeding is going to happen whether you had a vaginal delivery or a C-section, correct?
That's correct. I think the one difference with the C-section is that in order to close the uterus up, we actually have it in our hands. And so, not only can we see what's going on there, we actually clean the uterine cavity where the baby was with a cloth and kind of take out a lot of the pieces of membrane from the amniotic sac and any debris that was on the baby. And we kind of wipe that all out. Whereas with a vaginal delivery, you can't do that.
Right.
My patient would kick me in the head if I did that. So it's a little different. And I do find that in many cases, those who have had a C-section have less bleeding than those who had a vaginal delivery.
Yeah, that makes sense. And I know from my own experience that, getting back to the oxytocin, that if you are breastfeeding, when the baby triggers the release of oxytocin, a lot of the time women feel that cramping in the uterus because the oxytocin doesn't just act in one place.
Yeah.
So that's not uncommon to feel some of that discomfort, but it's actually helping with the whole process.
And that's one of the benefits. I think that was the design, that breastfeeding actually helps to prevent heavy bleeding in days and weeks after the delivery of the baby because of that release of oxytocin, which causes the uterus to contract. So another reason why you should breastfeed.
Yes. And then is there also sometimes localized bleeding? Like if there's a tear or something like that, can you have more localized?
So any type of tear of the cervix, tear of the vagina, tear on the outside and the skin of what's called the perineum, that space between the vagina and the anus. The degree of tear, of course, will determine the degree of bleeding.
Yes.
And any of those places can cause that. There also can be bleeding from retained tissue. So one of the things that I always do is I always look at the part of the placenta that was attached to the mom and just make sure that all the pieces are there. Find a big chunk missing, it's someplace.
Right.
So I have to make a search to find out whether it's just sitting in the vagina and we can just take it out.
Right.
Or if it's still attached to the uterus, which can cause prolonged bleeding along with other things.
Right. So we've got a range of what's normal, and we are being closely monitored for 1 to 2 days after having our baby in the hospital or by a midwife if we're at home. And then what happens? So mom's kind of on her own and is going to have continued bleeding for a certain period of time. And how does she know what to expect and when to get worried?
So I think understanding what that continued bleeding is, the placenta was attached to the uterus, and that site where it was attached has to get absorbed. It's not placental tissue, but it's different tissue, I'll say, than the rest of the uterus where the placenta wasn't. And so we call it the placenta site. And, as that gets absorbed, it kind of releases both blood and fluid. And that blood and fluid is what's called the lochia. That's one of those Latin words that we don't need to know.
Yeah.
But what happens is the bleeding and the things coming out of the vagina kind of go through stages, where at first it's kind of bright red blood, and then it becomes kind of brown blood, and then it becomes kind of this tan discharge, and then eventually it becomes white, and then it disappears.
Okay.
And so the length of time that it takes to go through each one of those stages is completely variable. But usually I find within the first 2 or 3 weeks, it's pretty much coming to a close. There are some women that have it for longer than that, but usually it's around 2 or 3 weeks. So it depends on how your doctor's office is set up. I like to see my patients in 2 weeks after they deliver.
Okay.
And
It's actually the recommendation now, right?
Yeah. Some people still do the 4 weeks. And I think it's a great thing to do 2 weeks because there's a lot of things that can happen in the postpartum period. And you just want to check and make sure that everything's going okay.
Yeah.
And the bleeding is one of those things. You want to know if the bleeding that the woman is experiencing within that range of normal. And if it's not necessarily that you have to do something about it right then, but you need to make a plan for following it up. Because you don't want to have her come back at the 6-week visit and tell you, oh yeah, I've been bleeding the whole time.
Right.
Because that's probably
right. Okay. And is it possible sometimes that the bleeding will go away and it'll come back and it's not a period, it's still something having to do with the delivery?
That is definitely one of the common things that can happen. Usually it's more like it's getting lighter and then all of a sudden there's a clot that comes out. And I think, looking at what my patients will call the office for, a lot of times they pass a blood clot and they want to know, well, is that normal? And sometimes they take pictures and send it to me to show me,
Oh yeah,
which
the joys. You get to see blood clots, I get to see poop.
yeah. Oh, okay. But blood clots are just blood that has collected somewhere, and blood always clots. It just gets like jello. I mean, that's the best way that I could put it. When it's in the vagina, it takes on the shape of the vagina, so it can kind of come out oval or circular, and then blood clots are affected by gravity just like everything else, and eventually they pop out. In the great majority of cases, it's fine. It's not something that is overly concerning, unless it's in the context of heavy bleeding after delivery. Then we do a little bit more evaluation to find out why that's happening.
Okay. Or you pass a clot and then suddenly you start bleeding a lot again. But if it's just an isolated clot, it's probably just some leftover blood that needed to find its way out.
And it might have been there for a while.
Right. Yeah.
But gravity took a little while to bring it out.
Okay. Are there other things that might make one worry more, like in terms of there's a fever and bleeding, or there's pain and bleeding, or things like that?
Definitely infections can cause the uterus to bleed longer. And partially it's due to the tone aspect of things.
Yeah.
An infected uterus doesn't clamp down as well as a normal uterus. And also, when that lining of the uterus, called the endometrium, gets inflamed, it's just like any other tissue. It tends to get very weepy and it bleeds, and you see that eventually come out in the vagina outside. So, the pathway that we expect to see is bleeding slowing down, no fevers, cramping getting better over time, and no foul smell. And if any of those things do come up, that's something that I usually want my patients to come and see me for.
Okay.
Sometimes there can be what we would call a subclinical infection there, where there's some germs that are in there that are causing bleeding, but not enough to cause severe fever and increasing pain. So most of the time, we see that in the patients that come in with prolonged bleeding most of the time.
Okay.
And we do a workup, ultrasound and examination and everything, and we don't find anything. And then there may be a little bit of tenderness on touching the uterus, but not that the patient feels when you don't touch it. And so sometimes we treat with antibiotics for a week, and then suddenly the bleeding stops. Solves the problem. One thing that we didn't talk about, which is very important, is that many times women have disorders in clotting of blood, certain hematological problems with the blood and with the clotting chemicals in the blood. And many of them find out about these problems during childbirth.
Yeah.
Where you have somebody who's prolonged bleeding, you're doing a workup to figure it out, and you kind of look into that, and suddenly you find that they have something like von Willebrand problem with the clotting of the specific blood chemicals that cause clotting.
Yeah.
So that's something we always keep in the back of our head. Many times, those patients, when you ask them, they will give you the history that their mother and their aunt and their cousin and sister have problems with bleeding.
Right.
And when you test it, you'll find that they have that. It's hereditary in many cases, and you'll find that they have that too.
Yeah. And we see that also sometimes just with heavy periods. That's how it gets discovered as well. Okay. So let's go through kind of the course. This is really helpful to just kind of know what's normal, what's not normal. And what do we expect then? So after the postpartum, the directly postpartum, let's say that first 6 weeks or so, or 8 weeks, what do we typically see in terms of when is the period potentially going to come back? And when it does, is it going to be kind of immediately like it was before we got pregnant, or should we expect something different?
Yeah, I think there's a wide range of experiences, and part of it will depend on if the person is breastfeeding or not.
Mhm.
So, breastfeeding typically tends to delay the onset of the period. That's not to say that you won't absolutely get a period if you breastfeed, but usually it's not monthly if you have one at all. It may be here and there. So, I also have like a lot of patients who will breastfeed for like a month and then they stop. And that kind of delays the onset of the period because it's kind of like the body will reset itself at the time for having a period, that is, will
Okay.
reset itself at the time that breastfeeding stops
Okay.
or soon after. And so I find that it may be a longer period of time before the first period comes back. Then for those who haven't breastfed, usually I would say somewhere between 6 and 8 weeks after delivery, the
Okay.
period should come back after. Now, in terms of what that period looks like, that's really variable.
Okay.
Some people have a nice normal period like what they had before. Some people, their history is that they've been on some type of birth control method, came off the birth control method, got pregnant, and then after the delivery, it depends on if they're going back on the birth control
Right.
or if they're not going to use it, then many times the period that they experience not being on anything is different than they experience being on birth control method. So many of my patients will start on a birth control pill or some other hormonal type of medication beginning about 4 weeks after they deliver. And so their periods may be different than my patients who don't use anything at all.
Right. Or you may choose a different method of a different kind of pill if you're breastfeeding potentially. So that can also lead to differences. Yeah.
Yes, yes. But, sometimes that first period after delivery is a little wonky. It can be like less than normal or longer than normal. It can be a little bit heavier than what you normally expect. I have patients who will call me up and say, "Oh, my period's horrible. What's going on?" And I'll say, you know what? Give your body a chance, see what the next period is like. And if the next period is crazy like this one, then come back to talk to me. But
Yeah.
if not, then you're good. And what I find that most of the time, by the second or the third period, you're back to normal. Patient is fine.
Yeah. I guess it's kind of reminiscent of what happens when girls start menstruating, that things
Yeah,
are a little wonky for a while and
yeah,
then your body
yeah,
kind of regulates.
absolutely.
Great. Anything else that you think in particular we should know?
Well, I'll mention something since you are the expert, and I'm sure you tell your patients this, that lactation can help prevent you from getting pregnant, but it's not the best form of birth control.
Right.
And you can get pregnant while breastfeeding. And
Absolutely.
so if that's an issue for you, then use something else.
Right.
Long.
If you're intending to use that method, we call it the lactational amenorrhea method, you have to meet certain requirements for it to be more likely to be effective. So it's important to kind of do a little bit of research on that. But even then, it's not 100%. So I think people who use that method need to
And I,
know that it could happen.
and I think the thing that gets my patients confused with that is they're not having their period. So they assume that they're not ovulating.
Right.
They're not releasing an egg. And that may not be completely true. Most of the time, it's true,
Right.
but may not always be true.
Right.
And most of the time, I think it's more like it was meant to be, just because this wasn't anything that could be predicted by anyone.
Right, right. Plus, you ovulate 2 weeks before you get your period, so you don't necessarily know when that first period's coming,
That,
and
that's correct.
might be too late. So, yeah, something very important to remember.
Yeah.
Well, that's been very, very helpful. I wanna know a couple more things that just might help our viewers, might just be
Mhm.
interesting to me. So, I'd love to know, so you live in Suffolk, Virginia, and I don't
Yes.
know that much about Suffolk, Virginia. What is something that you love to do there? Like, what's a
And so,
really fun activity or something that you enjoy about Suffolk?
well, I could tell you something that I found interesting about
Okay.
Suffolk. I came here about 16 years ago, and I work in a hospital that's called Centera, that's the corporation, Obici, Obici Hospital. Have you
Okay.
ever heard of that name, Obici?
Nope.
So Suffolk is very, very famous for one. There was a gentleman whose last name was Oversea back in the early 1900s, 1920s, I guess it was, who was a immigrant from Italy and came to the United States, settled in Suffolk, Virginia, and realized that peanuts grew very well in Suffolk and started a peanut farm that eventually became a big, huge company that we all know and love, Planters Peanuts.
Oh,
So Planters
wow.
start in Suffolk, Virginia,
From a
and
with an
Obici
Italian.
family from an Italian. And the Obici family made so much money when they had died, they gave all of that money to the city of Suffolk. And his wife, Marie Obici, was very much into healthcare, and she was a nurse and was very key in starting a nursing school, nursing program. And so they donated money to the city, and the city used it to make Obici Hospital, which to this day has a nursing program associated with it. And so if you ever eat Planters peanuts, you'll remember Suffolk, Virginia.
I will. I will. And I don't know why. I just feel like peanuts are such an American thing. I mean, I guess they were in America, obviously, but Italy I associate with wine.
We do have some wine groves or grape groves in Virginia, but they're
Okay.
not in Suffolk.
Okay.
Those are mostly as you go out west.
Okay. Interesting. All right. And then here's another question. So,
Okay.
what would you tell your 20-year-old self if you could go back and talk to your 20-year-old self? What piece of wisdom might you impart upon him?
So 20 years old, I would have been in medical school
Okay. Mm-hmm.
at that time. And I don't
Wait,
know,
already in 20 at 20?
20. Oh, no,
College.
that's college, yes.
Yeah.
College, I don't know. I would probably just give myself encouragement to just keep on going and maybe tell myself some things that slowed me down as
Mm,
time went along. But you know something? I think the one thing that I've learned is that even the hard things in life, it's probably good that you do go through them.
yeah.
And the reason is because they make you who you are.
Yeah.
You know, there's some really hard things that I've gone through as a physician that at the time I was like, oh, this is horrible. Why am I going through this?
Right.
But as I look back, I'm kind of really thankful that I went through that because I would have never have learned certain lessons and certain things about life if I hadn't experienced that.
Right. Right.
So that's a hard question to answer because I wouldn't go back and say, look, don't do all these things because you're going to have all this hardship in your life. And I probably
Yeah.
would encourage myself to, no matter what happens, keep going. You're going to make it one day.
Well, it's interesting that you say slow down because when I went to college, I didn't have to pick a major before I went to college, but I feel like people have to declare their major before they even start college these days. I feel like people are being pushed to move faster even now, which I think is not necessarily the wisest way to do things. Like I had no idea what I was going to do in college. I did not do pre-med and didn't figure that out till afterwards. And I think that, like you said, I think that helped me get to where I am.
I think for me, I had a little different. My father used to always say that, you know, how you go up to a little kid and you say, oh, what do you want to be when you grow up? And from the time I was 3 or 4 years old, I would say, I'm going to be a doctor. I'm going to be a doctor.
Really.
I'm going to be a doctor. So we have a running joke that my grandmother, whenever she would hold me, she would just whisper into my ear, you're going to be a doctor. You're going to be a doctor. Because from a very young age, that was what I wanted to do. And the thing is, I went from kindergarten straight through without a break. And that was always so
Wait,
I didn't have that point where I had to decide. I decided from really early.
When did you figure out that you wanted to do OB-GYN?
Ah, that's a funny story, actually. When I was first in medical school, people would come up to me all the time. Oh, so what specialty do you want to go into? And I would tell them, well, I know what I don't want to go into. I don't want to go into OBGYN and I don't want to go into peds.
I knew you were going to say pediatrics, but I didn't think you were going to say OB-GYN.
I told everybody that for like the first 2 years.
Wow,
And then
interesting.
third year, there were two things. I did a rotation through surgery, and I had wanted to be a surgeon. I actually wanted to be an orthopedic surgeon.
Okay.
And I did the rotation through there, and I was completely miserable. Completely miserable. Like, I think I was like depressed when I did that, because I would come home after, as a student, doing that rotation, and I would sit on the corner of my bed and I would just cry.
Oh my gosh.
And, you know, for a guy, big tough guy, to cry every night, that's pretty sad. Because it was just horrible. And then back in those days, things were a little bit different. It was in some ways a lot busier. And I remember when I did my OB rotation, you know, being on a unit where it was so crazy that all of the rooms were filled up and we had patients in the hallway.
Oh, wow.
With little curtains to block them off from the other patients in the hallway.
And they were in labor?
Yeah, who were in labor. And what would happen is that the nurses and the doctors would be in another room doing another delivery. And me, as a little medical student, I'd be in the hallway and the lady would say, oh my gosh, the baby's coming, the baby's coming. And I got to do deliveries just because I was the only one standing there.
Yeah.
I don't think that happens that way anymore. Those were the old days. But that was quite an experience for me, that I actually got to deliver a baby by myself. Eventually they would come. We would yell out, baby coming. The nurses would run to us, but I would have my hand on the baby, you know, catching it. And literally, that's pretty much all I did was catch it. I didn't know how to deliver a baby too well. So,
yeah.
But I think that was just a good experience. I had a good experience. I did that rotation actually first, and then I did the surgery rotation afterwards. And so it was like, hey, that was pretty cool. I like that, you know, and it was such a broad field because I'm a surgeon. I do many different types of surgery, and I have the primary care type thing, helping people with their health maintenance, and then this whole range of electrical things, which is unlike anything in medicine.
Yeah, yeah.
Look at that. I get to take care of two patients at the same time.
Right. But yet you still don't have to be the pediatrician.
No, it's actually funny. That's continued to this day, you know, because when I go in the room and the patients ask me, oh, when is the baby going to get such and such test? I'm like, ask the pediatrician.
Not me.
Took good care of the baby when it was inside you.
Yes.
Send them to Dr. Rubin.
Well, thank goodness that there's such a wide variety of what people are interested in and our personalities. Yes. And so there's somebody for everything.
Yeah. I work with a great group of pediatricians, so they do a great job. So I don't have to worry about those things.
Good. Well, this has been wonderful. Thank you so much for joining me.
Oh, it has definitely been my pleasure.
Very, very, very important information for us to know. And so I said it a little bit, but if anybody would like to reach you looking for an OB-GYN in Suffolk, Virginia, or has other questions for you, what's the best way to reach you?
Probably the best way is to go on the website, which is Lifetime Women's, the E, WOMENS, health.net.
Okay.
Somebody had the com, so I couldn't get that.
Yeah, there are worse things in life. Great. And I will put that in the description of today's show as well. So thank you, Dr. Wing. It has been a pleasure. And again, we will answer questions. If people throw questions into the chat, we'll keep an eye on that and give you answers later on. So keep an eye out. And thank you for watching Keeping in Touch. And we will see you next week. Bye.